to Heroic Herstories, Women in Medicine with the Katies. This podcast is to document the stories of women trailblazers in medicine in the state of Iowa. We will highlight seasoned women in medicine to create a brief oral history of their works and lives. We want to learn from their experiences, share their vast knowledge, and gain insight into the challenges they faced. Our goal is to lift up those who've gone ahead of us and thank them for their incredible service and dedication to our wonderful field.
Hi, Katie.
Hi, Katie.
We are so excited to welcome our guest today, Dr. Lisa Veach. Dr. Veach, how do you want me to refer to you today?
Lisa works great.
Okay, all right. Lisa was born in Webster City, Iowa, and I did some Googling on this. Population 7,713. I think it was 8.8 square miles in area, and also referred to as Boone River County. Is that right? Or Boone River Country, maybe? Boone River Country.
Boone River Country.
Okay.
It's Hamilton County.
Oh, Hamilton County. Oh, perfect. I did see that. Okay. And then attended the University of Iowa for her undergraduate studies and medical school. She graduated at the top of her class and earned entrance into the AOA Medical Society and was also awarded the Janet S. Glasgow Award of Achievement. I was just impressed that this was named after a woman. And when I Googled that, it looked like it was for like the top woman in the graduating class. Is that right?
No spoilers, Katie. We're going to come back to that.
Oh, sorry. Okay. We were doing investigative reporting. Okay. All right. And also the Seblin Award for Excellence in Internal Medicine. She completed her internal medicine residency in 1985 at the University of Iowa and then continued on an infectious disease fellowship, which she completed in 1987. She then spent 1 year as a chief resident and was a fellow associate in clinical epidemiology for 1 year. She then left the great state of Iowa for a state that is sometimes confused with Iowa because it also has many vowels, Ohio. She there worked at the University of Cincinnati Medical Center and worked as a member of the AIDS Clinical Trials Unit in 1989 to 1990. She then returned to Iowa and worked in Des Moines, seeing patients, being the medical director, laboratory director, and hospital epidemiologist. In 1994, she became the division director for infectious disease and the assistant program director at the University of Iowa Des Moines Internal Medicine Residency Program. She remained in these positions for over 20 years. She won many Internal Medicine Teacher of the Year awards, was awarded the Laureate Award for the Iowa chapter of the American College of Physicians. She has been and remains very active in many committees. Some include the AIDS Advisory Committee and the AIDS Education Committee, medical staff president in 1998, and the Iowa Methodist Medical Center. She's known across the state as an amazing clinician, educator, and overall powerhouse. And we are so excited to welcome Dr. Veach to our podcast today. So thank you, Lisa, for joining us. So happy to have you.
Thank you for the invitation.
Yes.
I learned a little bit about Webster City even.
I was going to say, I don't know how long it's been since you've lived there, but I think that census was 2023, though. I should put that out there.
Yeah, that's about what it was when I was growing up. But yeah,
it sounds like they need more marketing for the Boone River Country title.
Yes.
Maybe.
Actually, if you're a canoeist, it is a great place to put your canoe in and paddle down the Boone River.
Nice.
Mm-hmm.
That's a good idea, Katie. We should take the podcast up there.
Yeah.
Let's do it. Go on the road.
Yeah.
I love it.
So speaking of Webster City, Wikipedia also tells us that it has a hot summer, humid continental climate. We're wondering if you had to describe your personality in terms of a weather pattern, what's the forecast?
You know, I guess I'll describe it as mostly sunny, but with an eye out for disasters. That's fair, being an infectious disease physician in the era of HIV and COVID and now measles. So, but taking a positive outlook. Kind of a drama down girl. So
I love that. I love it. We are too. I think we're drama down girls. Katie, would you say that?
No, drama up.
You are not a drama up.
Yeah,
or are you saying that about me? I don't know.
Somebody has to make sure there's excitement around here.
Oh, all right. Well, that's in your hands, Katie, not ours. Well, Lisa, one thing that we noticed looking at your CV, so some women have like very circuitous paths to medicine, and yours seemed more linear. And we were just kind of curious, what brought you to medicine? What took you there?
Yeah, I think I was destined from an early age, really, because my father was a large animal veterinarian. And I was from a family of three daughters. My older two sisters had no interest, but I loved going out on calls with him to the farms. So, seeing my father arm up to shoulder inside a cow, pulling a calf, but gosh, I loved it. It was just, I don't know, it instilled in me a love of the biological sciences. So I was destined early, I think. When I entered college, I thought I'd take the path of a medical technologist, but sort of out of the blue, my junior year, I took the MCAT and on it went.
Wow.
It sounds like gynecology might have been a more natural follow-up to that.
I honestly thought that's what I would do until I did my OB-GYN rotation, and
Couldn't get your whole arm in there.
yeah, I was going to say, if I can't get my up to my shoulder in there, I'm not going there.
Not worth it.
It's amazing. And you just said on a whim. So do you even remember, like, why did you go take the MCAT, or like what prompted that?
I should reflect on that. I didn't even tell my parents. So yeah, it was. I think growing up, I didn't have any women role models, so it certainly did not enter my mind as I entered college. I had some women, one woman friend in particular that I got to know taking science courses, and that's what she was doing. So I thought, yeah, maybe I could do that.
I love that. Even like the peers, right? Like lift you up
Right.
as well.
Yeah.
Yeah, I really hope. I mean, I have teenagers now, and I really hope that the worst thing they sneak off to do is take the MCAT. Like that's
Yeah, that was rebellious. Yeah.
a real rebel.
What did your parents say then? Like after, were they surprised that like, oh, by the way, I'm going to apply for medical school?
Yeah, I think they were a little surprised, but totally supportive.
Wonderful.
Yeah.
One thing that I noticed on your CV is that you did your ID fellowship and then you served as a chief resident.
Mm-hmm.
Was that common in that time where people would come back from fellowship to do that?
Mm-hmm. Yeah, I think that was very common at the University of Iowa at that point. I'm not sure when it changed, but it seemed like all of the chief residents had at least 1, if not 2 years of fellowship under their belt, and then would step aside and do a chief resident year, and then often come back and do a third year of fellowship. Yeah. And yeah, it was, and that probably gave us a little more chance to understand the workings of the university, and to learn how problems get solved and where to take what. And so it was a great experience. I certainly learned some incredible scheduling skills, when you have to do a call schedule. And so that has served me well, and really just learning how people cope with stress is very different, and that people have different coping skills. And some you can mentor them to develop better coping skills. So all of that's been very helpful to me.
Yeah, I agree that there's a big set of like HR learning objectives that come from being a chief resident, which,
Yes.
I mean, you in all your leadership roles since then, I'm sure those were valuable for you to have.
Yeah, and just how complex some of the HR issues are. You certainly have no comprehension of that prior to doing that year.
So we found out why you didn't do gynecology. Now I'm curious why you picked infectious disease.
Yeah, I think I've always had a love of micro, but maybe it dates back to my sophomore year in medical school. The microbiology course, everybody is given an unknown, a bacteria unknown that they've got to identify. I'm not sure they even still do that, since we have MALDI-TOF and all these other processes. But back in the day, we had to do all these biochemical tests. So we had an unknown. I actually was sort of going down the wrong path in the identification schema when I inadvertently left a tube with the swab in my drawer. And when I pulled it out 2 days later, I saw the red tinge, and I realized Serratia marcescens. So anyway, I lucked into that one, And I don't know, perhaps that just instilled or made it clear to me that my interest in that was something that I should in fact pursue. But we had great infectious disease physicians on staff and giving lectures and talks, and so they were very instrumental in that.
Maybe it was also that we're always asking, like, what animals are you around? Like the infectious disease people, right? It's like,
Oh, yeah.
did you grow up on a farm? Have you picked up roadkill recently? Have you?
I will tell you, there's almost nothing more fun than to go see a patient with a fever of unknown origin and ask one of those questions and have an aha moment. Now, it doesn't happen all that often, but when it does, it's like, yeah, that's why I'm doing this.
How satisfying. Yeah.
Yes.
Oh, that's awesome.
Weirdly,
Great.
but it is.
Yeah.
And so you've been in infectious disease in a really interesting era of history where you've experienced an epidemic and a pandemic in the course of your career. Can you talk a little bit about your experiences with HIV early in your career as a fellow and as an early career physician?
Mm-hmm. Yeah, I sure can. That was, as I reflect back, that was the most challenging time in my career because HIV was first described in June of 1981. So I was just entering my third year of medical school. But by 1983, we had a test for the virus. And then 1985, we had AZT. So we had the first drug that was available to treat HIV. But as everybody knows, AZT by itself was beneficial, but only for a short period of time. So we were treating generally very young patients, mostly men, but there were some women. There was a lot of stigma associated with HIV. So helping patients and their families deal with that while they were suffering horrible opportunistic infections or cancers, dying of wasting syndrome, it was really a rough go. And then in 1996, the protease inhibitors were available and everything changed. Prior to 96, we had access to some of the newer agents that were not yet FDA approved, and that was through the amazing work of Dr. Anthony Fauci and others, and that was called the Compassionate Release Program or Compassionate Use. So many of my patients were beneficiaries of that, so they were pretty advanced, but we were able to treat them with some combination therapy or some newer drugs prior to FDA approval. And with that, they were able to survive long enough to benefit from the protease inhibitors. So that was hugely rewarding, but those early years in the early 1990s were really very challenging.
So right about then was when you went to Cincinnati, like in the middle of that time period. Was that what took you there, was to do HIV work there?
Yes, that, and I was offered a clinical teaching track at the University of Cincinnati, which is really what I wanted to do. And I benefited greatly from being involved in the AIDS clinical trials unit in that year that I was in Cincinnati. So when I left the state of Iowa, we had 80 patients on the state HIV registry. And when I arrived in the city of Cincinnati a day later, there were 800.
Yeah.
So it really was just hugely a big growing phase for me. Of course, our career always is that, right? That continues to this day, but that was pretty intense.
Wow. I was just thinking also, the miracles of science, right? But that time period between AZT and protease inhibitors for patients, that's terminal for so many of them. And just, I mean, gosh, I was just thinking how hard that must be to have your like long-term patients where you just don't have other things to offer.
No, that's right. And I was not trained in end-of-life care. I mean, especially for a 30-year-old.
Yeah.
So I had several internal medicine colleagues who were obviously very helpful in helping folks helping our patients during that phase of their life. And I do reflect, I've got several patients now who are alive and doing well, living their lives, having children even that were beneficiaries of that. But I've got others that didn't quite live long enough to make it to 1996. And that haunts me.
Oh gosh.
So then you came back to Des Moines, and I'm just, thinking about that, like the 10x, number of patients you were exposed to when you went to Cincinnati.
Mhm.
What was the delivery system like for HIV care when you came back to Des Moines? I imagine it was very centralized in probably here in Iowa City at the university and in Des Moines.
Yes, I'd say that's right. And there wasn't the army of people available to help in that care like there was at the University of Cincinnati, where we had, a social worker and several nurses that were dedicated to that. So it was trying to do what I could do to develop a team approach. But yes, I think between really just Des Moines and the University of Iowa, I think there was an infectious disease provider in Dubuque as well, right? I know that there was. So there were some islands of care. And really, patients obviously are hugely grateful to get care locally rather than have to travel. But I was surprised. I detected a little hostility in some of the other healthcare team members because they just weren't familiar with HIV. And of course, there was a lot of fear about transmission. What was the risk to them, risk to their family? So in my first couple of years, that was the goal of mine, was to help people really understand what the risk of transmission was and learn to manage that so that they could in fact be a part of the team and care for patients too.
Yeah, I was so curious about that. The physicians' reactions to you taking care of patients. Because just in COVID, I saw a lot of physicians that really didn't want to see patients, and and I'm sure I'm guessing, I don't know. Can you compare the HIV times to COVID times?
Oh, absolutely. There were a lot of similarities, but there were a lot of differences as well. Obviously, fear was big in both. But COVID just exploded on the scene, whereas HIV was more of a slow burn or a slow roll.
Mm-hmm.
One thing that was in common was what I mentioned, that there was still a personal fear for some providers. For many, that wasn't part of it, and that they were more understanding of or more confident of standard precautions in HIV care, and then the special precautions that we took during the COVID times. But yeah, I've thought a lot about being a part of both of those epidemics. And when COVID, I often will say, and borrowing from Dickens, of course, it was the best of times, it was the worst of times. And it's obvious why it was the worst of times, right? So many deaths, so many patients dying alone,
Yeah.
such pressure on our nurses and the entire healthcare system. But for me, it also had some of the best of times because I was able to, in my role in infection prevention, connect with many leaders and amazing people across our Unity Point Health system. Because we're 7 regions or 7 kind of regional hospitals or markets, so including one across the river in Illinois and one in Madison. So we did have 3 state health departments to incorporate in our decision making, but it did provide that opportunity. I was a little sad that as a nation we couldn't continue to stay united and recognize COVID as our common enemy instead of becoming divided. But at least early on, man, we were all together, and COVID was the enemy to conquer.
Yeah. We talked about this with another person, but just that, like, the feeling when the vaccine came out. Oh my
Yes.
gosh, the elation. Like and I remember like being mad because I remember like somebody who wasn't in direct primary care was getting one before me. And I'm like, how come I don't get to get one? I was so jealous.
Those were some of the really tough decisions that we had to make, because so early on we were dealing with supply shortages and we were dealing with who could get tested because people kind of forget, but early on testing was very limited. And then testing became unlimited. And then we had even bigger, well, we still had questions. When to apply the test? Do we really test every asymptomatic person on admission? Or when does that become more of a problem than a help? The vaccine, coming up with a plan for deployment of the vaccine early on, because yes, I think everybody can remember the day they got vaccinated.
Yep.
It was December 13th,
Absolutely.
2020. And if you think about it, that having a vaccine less than a year
Exactly.
after it is very, very remarkable. Thank you to the people who led mRNA and basic science research, one of whom was a woman. I think probably people know that story. So
I clap for them. I'm just still so excited. Like, it's still
Yeah.
amazing to
Yeah.
me. Yeah.
I said before we started this that I hoped I could hold it together, talking about HIV, but that's the other one that'll get me, is thinking about the day I was vaccinated.
Yes. Yes, I know. Photographic. I remember being like, I'm getting a picture. I'm so excited. Yeah. Yeah. And I guess I just have to bring it up right now, but measles now. Now measles. Any thoughts on that you'd like to share?
Yeah, it is a result of vaccine hesitancy and vaccine misinformation. And I think it's also a result of us, when I say us, I mean just the bigger community, of not doing a good job of making sure people understand the scientific method. And during COVID, we had to pivot. Once more information became available, we would pivot. But I think a lot of people in the general public took that as, oh, gosh, they never knew what they were doing in the first place. So why would we pivot to this now? They don't know what they're doing. So it did instill even more disbelief or lack of understanding of the scientific process. And I think that's added to the vaccine hesitancy. But, we've got a vaccine that prevents disease in 98% of people. And this virus does not have the capacity to change like COVID does, like the SARS-CoV-2 virus does. So we just have to keep reminding folks, or doing what we can to instill the belief and the understanding that the vaccine is safe and it's incredibly effective. Yes, there are going to be some breakthrough cases, but those are very rare and unlikely to transmit further. It's the unvaccinated people that are at risk.
Is there anything that you feel like you could take directly as a lesson from COVID into measles in terms of like your role in infection prevention that we didn't know before, maybe?
Yeah, I think one thing I took away from COVID, when I would talk to some of my patients who were vaccine hesitant, maybe not necessarily hesitant to get the first one or two, but then hesitant about boosters or additional vaccinations, I really took the time to drill down what was behind that. Was it that they were worried about adverse effects, or were they thinking it really wasn't necessary for them for prevention of disease for them, or protection of their family? So if I couldn't get an idea of which one of those was behind their vaccine hesitancy, I understood that it was often just something that they heard on their social media or their news outlets. And sadly, I came to realize that that's harder to conquer or to influence than if it was because they themselves had thought through it, and they just weren't sure that it was necessary or relevant to them. So I would take the same approach with measles. So in trying to help people think through the vaccine question. Now, the infection control part of it is, we know what needs to be done for measles. It really is it's a full court press, so to speak, right? The airborne isolation is necessary. For COVID, that morphed over time, and currently we are still doing, the N95 and eye protection and contact precautions, but there are several hospitals that have backed away from that, at least getting rid of the contact precautions part of it. I think that's a work in progress at Unity Point Health and the University of Iowa as well, and really across the nation. So I just know that when we do pivot, we're going to have to make sure we explain that well. So it's going to continue to be a big challenge.
Yeah. Understandable. I was going to ask that, it looked like pretty early in your career, you got involved in resident education at the Des Moines Internal Medicine Residency Program. And how did you get into that? I think a lot of our listeners, we really don't know if there will be more than 5, but a lot of our listeners love, resident education and are curious how people kind of got involved in that. So curious how you went about that.
Yeah, I think for me it was almost expected when I joined the group here in Des Moines, because I was the only infectious disease provider. So I was a group of one.
N of 1. Okay.
But boy, what a gift that was to me, because I got to work with all of the internal medicine residents. At that time, we had 8 per year. So 8 of the second year residents would spend a month with me. That, as you know, there's nothing like teaching to make sure you know your stuff.
Yes.
If you can explain a process, like how it is that TB goes from the air to and ends up in somebody's kidneys,
Yeah.
Or how to read an antibiogram. So that was just really hugely beneficial to me and to my patients. I thought, to be so involved in the teaching program. Now, I do want to admit that after about 4 or 5 years, I came to understand that I was viewed as maybe a bit on the demanding side of the residents' part. So I did try to soften a little, but mostly I made sure that when I was orienting a resident to the rotation, I made sure they understand that I had no higher expectations of them than I did of myself. And I'll admit that I am a little obsessive about continuity of care and ownership of the patient and how and their outcome. But I wanted to instill that. I hope I have.
Yeah. Well, I think one of the main things is we want doctors, like those that we're helping teach, we want them to be better than us, right? So it's like, I want you to do a better job than I do. So
That's right.
yeah.
No, I had several people at the University of Iowa that, so to speak, held my feet to the fire, but in a supportive way, not in a aggressive or demeaning way. But I still think that's important in our learning process. So.
Well, and it sounds like your, kind of key expectations that you had of them were very clear, right? You were, they're things that I think all of us would say are excellent qualities of an internist, that continuity of care and that ownership and over every aspect of the patient's care. So it's not as if you were like, capriciously deciding that you didn't like their tie that day and or something that was not doable for them,
And I wasn't into asking random questions.
Right.
If I asked questions that had to do with the patient that we were seeing at the time. So I would hope that people would be motivated to read about your patients, right? Still probably the number one way to learn.
Yes. Yeah, absolutely. We were laughing. We never know when this podcast will be published, but it's the first 2 weeks of July, right? When we're recording this. And I was just on hospital service and the senior said, they asked me about SIADH and I really have to think about that again. And it's true. It's like, and that's what our lives as educators, right? It's like, how does that work? It's wonderful reminder.
So much of it, we're educators of patients too.
Yes.
So learning those skills is very helpful.
Yeah.
In addition to your teaching roles, you've had some significant leadership roles in the hospital system, which we've talked about, in infection control and epidemiology. You were the medical staff president. My experience observing these types of leadership roles is they seem really thankless, but they are also really vital to the, well-being of a hospital system. So how did your administrative leadership inform the clinical and education aspects of your career?
Yeah, I think those leadership roles were really critical to helping me grasp just how complicated it is to keep a healthcare system afloat. Knowing the depth of maybe some regulatory issues or accreditation issues or things that you wouldn't otherwise know or understand is important, and it is helpful to impart some of that understanding to residents as they're training, because I don't think they really know that I spend time with the surveyors when they come around to make sure that we're doing the right things in infection control. And of course, that applies to every aspect of the hospital. So that was definitely hopefully beneficial to the residents to have a small understanding of that. And I learned that again through my leadership roles. I think I sort of blame my parents, jokingly, because they taught me, if somebody asks you to do something, you better do it. So part of it was that, and it was, an honor to me to take on some of these roles. So I'm thankful.
Yeah, I think that's like, I always say that like part of the residents benefit package is the right to complain, right? Like I think they're not very well paid, so they can at least just complain about all the things that they're asked to do, and I'm like, okay. But I do think it's an interesting point that you make. Like if you are that administrative person who's making the rules, you're not making them up. Like they're coming from somebody higher than you who says we need this to target this or fix this. And that is, when you're farther down in the hierarchy, it can feel very like you're put upon, we have this extra thing that we have to do.
Exactly.
And it's really hard to understand those things. And you are right in the middle where you kind of know the experience of everybody involved. That's interesting.
Yeah. I always told the residents, listen, I'm as annoyed as you are, but this is something we've got to manage. And one thing I learned when I was a chief resident was that I always told the residents, my door is always open to hearing about problems or hearing about complaints, as long as it's accompanied by a potential solution or a potential approach to the problem, right?
Right. Yeah. I always just think back to residency, and I feel like my scope was so narrow, right? I mean, you're taking care of patients. That's what you do all the time. And there are just so many things going on, behind the scenes and around the hospital that there's no way they could know about it. It's just fascinating.
No, that's right. That's part of
Yeah.
the process. I remember early on, it was all about the science. Okay, the science of their disease process or the medications we were giving them, and I couldn't even contemplate factoring in their socioeconomic status or their multiple barriers to healthcare. And now, and it took me a while to realize, oh my gosh, that's probably every bit as important. So there's so much to learn when you're a resident. It's just such a steep learning curve, as we all know.
Yeah, absolutely. Well, we wanted to also make sure that if you had any stories that you wanted to share with us that we haven't asked about, to give you some time here. So anything you'd like to share?
Oh, that's kind. I'll share one story. I've got a couple of funny stories about things that I did that I can't believe, that I said. You're like, did I just say that?
Yes.
We can circle back to that if you want to, but I did want to share one story that's just incredible to me. I keep coming back to this, and I'm just so honored to have been part of this patient's care. This was a young woman. Gosh, she was probably only 22. So she had severe pneumocystis, such that she was on the ventilator even. And the look on her mother's face at bedside said it all, right? She just disbelief and grief and fear, mostly fear. But fortunately, this patient survived her pneumocystis, and the timing was such that these new drugs were available to her, and she responded very well. Her boyfriend at the time, who had just become her fiance, was uninfected. They're married, have healthy children.
Oh, amazing.
And it's pretty incredible.
Oh my gosh. That amazing. Oh.
Yes. I always ask her to bring her kids into the visit. They're old enough now that they have no interest in that. But
wow, though.
But yeah, what an amazing journey for all involved. But again, just a lot of things lined up to be available to this patient, so she could have this full life and amazing children. In infectious disease, I do see a lot of patients at the end of their life, because that's one of the things that happens to people. And as organs are failing or at the end of their life. But there's also this aspect of infectious disease where we really can have long-term relationships with patients and be impactful.
Good.
Yeah,
Love
I
that.
think those are the kinds of things that keep you going, right? When you
Gosh, yes.
you know,
Right, because there are hard days where there's no answers. There's diagnostic dilemmas, and you're pulling your hair out, thinking, "What am I missing?" Or the days of when COVID was so intense, when there were hostile or angry family members. There's. I don't want to sugarcoat things and act like there aren't those challenges, but you're right. You keep coming back to these other stories.
Yeah. Well, we have our rapid fire or lightning rounds coming up, and we have a question that maybe could like get back to like, I can't believe I said that, but but I guess our first one that we like to start with is, if you could go back and meet yourself on your first day of internship, what would you tell yourself?
Probably tell myself not to be quite so serious. I was overly in tune to not showing any weakness, and maybe, because I think in my medical school class, maybe we were 25% women at the most. So yeah, I think I'd say ask for more advice, seek it out, and don't feel like you have to project such a serious, I'm a serious doctor, projection to in fact be a good doctor.
that's a good one. What was your favorite medical school class?
I bet you know.
Microbiology.
Micro.
Yeah, I think
Typical.
microbiology, although I love pharmacology too, that was pretty fascinating, but microbiology for sure.
That's very, I feel like most students, when they're in pharmacology, the antibiotics section is the looming difficult one. So I could see that.
Of course, back in my day, we barely had something. So,
Like 5.
yeah.
That's like immunology now. I'm like, we
Yeah.
had this teeny book for immunology, and now I'm like, what? It's
Right.
impossible. White coat or no white coat?
She's an
I
infectious
like-
disease.
Yeah, I'm a white coat person. I know some in infectious disease really think that could potentially transmit, infections, but honestly, if you wash your hands, it doesn't. So, yeah.
You heard it here first, folks. Put those white coats back on.
Jump from your coat to the patient, but no, I do wear a white coat, and again, I think that reflects my age probably, and just that back in it was important to establish your role. So I've kind of hung on to that for better or for worse.
The pockets are really handy too.
Oh, yeah.
Oh my gosh, yes.
I just get so hot though. I don't know. Yeah, I have dresses
usually
with
cold.
pockets. They're usually cold. Oh,
Yeah.
I get really hot.
Any embarrassing situations that you could share with us that you would laugh about now?
Oh gosh, yeah. I will share one that my daughter is also a physician, and so I've shared this story with her before, and she thinks it's a hoot. But I was seeing a young man, gosh, he was probably 28, with a liver abscess, and it was due to Fusobacterium nucleatum. But so it turns out he's Amish. One weekend I was making rounds, and there must have been at least 10 of his relatives in the room. Everybody is clearly Amish, but I'm talking with them about this infection, and I say, really, you just need to read about it on the internet. And of course, that's really not something that's available to them. But I walked out of the room and I thought, oh, did you just say that? But anyway, it was a Sunday on weekend call, so maybe I can be forgiven.
Yes. And how many times do we say stuff and then you're just like, oh my gosh, that didn't make any sense to them. Yeah, right? Can I pull that back in? Oh no. Oh. Favorite candy?
M&Ms.
Plain M&Ms? Peanut M&Ms?
Probably plain,
Okay.
it's all about the chocolate.
Yes.
Don't let anything get between you and the chocolate.
Yeah, absolutely. I'm with you. Yeah.
We have a historical woman in medicine that we like to finish our episodes with. You're welcome to stay, and it just takes a couple minutes. We just do a little teaching about a historical woman in medicine if you want to join us.
Yeah, I'd love to hear this.
All right, well, I did individualize it for you because of your amazing victory for the Janet S. Glasgow Award of Achievement in medical school. So I went back and figured out who that person is.
Oh.
Turns out, so we'll back up one step. Dr. Maud Glasgow was the initiator of that award, but she named it after her sister Janet, who supported her medical school journey. So Janet wasn't a physician, but Maud was. That was her sister. So she was a pioneer in public health and preventive medicine. She was born in Ireland in 1876 and emigrated to New York early in her life. She initially went to nursing school at Mount Sinai and then ultimately got her degree in medicine in 1901 from Cornell. She worked for the Department of Public Health in New York as a medical inspector, which I think must have been a real journey in late 19th century New York City. She was also an early occupational health physician. She was employed by the New York Telephone Company as the chief woman physician.
Chief woman.
I don't know if that means she was a physician for women or if she was just the chief woman physician. Who did physicals and public health education and looked after the health of the employees. She ended up getting a degree in public health from NYU, Bellevue Medical College, with a particular interest in the welfare of women. So she, as with many women in leadership at this time period, she was a suffragist, wrote a lot about equal rights for women, wrote a couple books along those lines. I found an article that she wrote that was published in a newspaper that was entitled, "For Protection, All Women Should Learn How to Box."
Oh.
So this was like apparently one of her public health crusades. And in there, she said, she was basically, her thesis was that women had this learned helplessness that they couldn't defend themselves. And that was to the detriment of the public health of women. And she said that comparatively few men are low and brutal enough to beat a woman when sober. And if the wives of these whiskey-maddened cowards were not held back by a false idea of their physical helplessness, they would need no appeal to the courts. So, yeah.
I would have liked to meet her.
That's exactly what I was thinking. Like, wow.
It's a little,
that was amazing.
It's a little victim blamey, but like I think to our 2025 sensibilities, but I was like, okay, like maybe learning how to punch, maybe that's the right thing. So that was kind of her vibe, and I thought she was kind of a fun writer. So she created the award, the Janet M. Glasgow Memorial Award, given by the American Medical Women's Association. And it's given to the woman who graduates first in her class, as well as then there are citations for women who graduate in the top 10% of their class. So I thought she was an interesting woman to talk about because of her connection to you. And because she, I think, again, in our current time period where there's a lot to advocate for, politically and at the state and federal level in terms of public health. I think she was a good example of somebody who took a huge interest in that immediately in her career and advocated for what she thought was important in addition to patient care.
Mm-hmm.
Oh, I love it. I love it. Wouldn't it be fun if we could have her on the podcast, huh? Right? Talk about boxing. I mean, she did it too. I'm like, did she take some boxing classes? Sounds like it.
We'd have to put a little explicit thing next to the title. Right. I think she seems like she would have had some curse words.
Well, Lisa, thank you so much for joining us today. It was so much fun. I hope you had a good time too. And yeah, thank you for spending time with us.
Yeah, no, I very much did. I just admire the two of you for finding the time to do this. That is super and really, really, again, very admirable because I know how busy your lives must be. So thank you for this opportunity. That's very nice.
Well, I think we both feel like this is the highlight of our week because we've got to talk to some awesome women that we've learned a lot. So it's been really great.
Absolutely.